Hi, everyone, and welcome to week 16. This will be the last official week before finals week. This is covering the musculoskeletal unit, so we will go ahead and get started. Just so you know, the things that are being covered in this unit are mainly things that we have already covered. So really on this last PowerPoint, I'm just going to go over the learning objectives for this lesson. But please know that most of this stuff you've already seen before. So hopefully it will serve as just a refresher for you. So the first slide here needs to focus on the major functions of the skeletal system. And these are the 5 things that the skeletal system really does for us. So it provides support and shape. Um, it supports the weight of the body. In addition, your skeleton is also the anchor for all the tissue that it connects to. It also protects all of our important organs, like the skull protecting our brain, or your ribs protecting the heart and lungs, your spine keeping your spinal cord safe. And then obviously the skeleton helps you to move, and it does this through the joints and connective tissues, as well as all the muscles that work together to move us around the world. And then one thing you may not think of right away is that the skeletal system also helps to store minerals because your bones hold many of the body's needs of calcium as well as vitamin D. And then lastly, the other thing that many people leave out when thinking about the skeletal system is that the bone marrow is at the center of your bones, and that produces the new red blood cells that our body needs, as well as the white blood cells that helps our immune system and helps our body overall stay very healthy. So the main parts of the skeletal system include the bones, the muscles, the cartilage, the ligaments, the tendons, and the joints. And then this slide should also, again, just serve as a refresher for you, as we did talk about this quite a bit during other lectures, but this is about labor pain. Labor pain obviously includes pain from uterine contractions, as well as dilation and just basic pelvic pressure. In addition, we can have some referred pain, such as back pain or leg pain that happens during the labor process as well. Remember that when we classify pain, we have multiple ways to do so. And labor pain is typically thought of as an acute type of pain, meaning that the duration wouldn't qualify it as a chronic pain. We know the uh, etiology, but we should also think about really the type of pain that it is. So typically we think of labor pain as a somatic type of pain, which you may recall comes from damage to musculoskeletal structures and also from some of the soft tissues. So this could include things like bones, muscles, skin, or mucous membranes. It's really the same type of pain that we get when we cut ourselves or when our skin is damaged or when our muscles are sore from intense overuse. But then there's also visceral pain, and this is most typically thought of as originating from the organs. Generally speaking, it's our body's way of telling us that we have an injury or something going on that's affecting one of our organs. This is usually a deep and dull type of pain, and our reproductive system certainly is no stranger to this type of pain, especially when it comes to labor. As far as intensity, well, I'm sure you can probably imagine, but labor pain has a very wide range of intensities of pains. And this also greatly varies from person to person, ranging from what some would perceive as a mild pain to a very severe form of pain. This slide looks at the pathophysiology of pain and mechanisms of initiation and progression of labor. And a few things to discuss on this slide. I guess first of all is that pathophysiology of labor pain. Again, kind of already talked about this on the last slide, and this is really from the multiple nerve pathways. But pain signals can come from the visceral as well as the somatic nerve fibers, and they travel to the spinal cord um, uh, from the spinal cords, the signals are related, or from the spinal cord, the signals are then relayed to the brain where they're interpreted as pain. So basically, it's from these somatic nerve fibers, they travel to the spinal cord, and then from the spinal cord, they travel to the brain where they're interpreted as pain. When it comes to the initiation of labor, we think of this as happening in multiple stages. First of all, we have that hormonal stage, and this is where the ratio of estrogen to progesterone increases. And we have this more contractile state of the uterus. Next up is that inflammation, and this develops in both the uterus as well as fetal membranes. And it's triggered by things like intrauterine inflammation and uterine distension, as well as sometimes perhaps maternal or fetal stress. And then we have that cervical ripening, which is when the cervix becomes soft, and this is from both prostaglandins as well as oxytocin working to make this happen. This is an essential process for dilation. And then lastly, this hormonal signaling is when the oxytocin levels increase even further and promote more prostaglandin release, which then causes uterine contraction. And that can be really full circle, basically, where this is just positive feedback where the oxytocin signals for more oxytocin, eventually leading to birth. When it comes to the progression of labor, those uterine contractions come into play and they can become more and more regular, more and more intense, which leads to further growth, further cervical effacement or shortening of the cervix and further dilation. I'm guessing at this point you already are well aware of this, but just to recap, our first stage of labor begins at the onset of the regular contractions and it ends when the cervix is fully dilated up to 10 centimeters. That second stage of labor is the time from when the cervix is fully dilated to when the baby's birth occurs. And that third stage of labor is from the time of the baby's birth until the time of the placenta is delivered. Next up is to discuss some of the tocolytics and the prevention of preterm labor. So tocolytics are really used to either slow down or completely stop uterine contractions when they happen during preterm labor. Remember that preterm labor is labor that happens before 37 weeks. Oftentimes, tocolytics can only delay labor by a few days, but in many times this is enough to get the patient to the appropriate care facility, like a NICU, or to administer things like steroids like bechamethasone or dexamethasone that can help speed up babies' lung development and really reduce their chances of having long-term health problems or complications after birth. I'll let you read over the information that's present on this slide, as I do believe it was all covered in previous weeks. But basically, beta blockers or beta adrenergic agonist like terbutaline work by stimulating the sympathetic nervous system, and this relaxes the uterine muscles. Calcium channel blockers like nifedipine block those calcium channels in the uterus, and this inhibits contractions. Magnesium sulfate also blocks those calcium channels. And then lastly, NSAIDs, or those non-steroidal anti-inflammatory drugs like indomethacin, can inhibit the prostaglandin production. And if you recall, this is also involved in uterine contractions. Next up is some of these common muscle relaxants. So this slide's going to cover the very common ones that help our skeletal muscles, that work as skeletal muscle relaxants. This works on the central skeletal system. So typically these are used short term for some types of injuries, and they don't work all the best by themselves, but when used in combination with things like physical therapy, rest, and appropriate medical interventions, they tend to provide patients with some really good and often very needed pain relief. So cyclophenazepam, or Flexeril is the brand name, can interact with some antidepressants, so it's important to keep that one in mind. It also is sedating. Methocarbamol, also known as Robaxin, is a bit less sedating than Flexeril, so it's often better used during the daytime. And then drugs like baclofen are better for spinal cord injuries, as it works on the spinal cord where Flexeril works on the brain, and it can be used longer term. That being said, you may need to taper off of this medication if you're using it longer term, but it certainly can be. And note that these are not routinely used during pregnancy due to very limited safety data. If prescribed postpartum, we want to monitor for things like sedation, dizziness, and compatibility with breastfeeding, obviously, if that's something the woman is doing. So we're going to talk about some of the pros and cons of induction and augmentation of labor. For induction and augmentation of labor, keep in mind that induction is really stimulating that labor artificially, whereas augmentation is enhancing existing labor contractions. In these cases, we need to balance medical necessity with patient autonomy. Using things like the Bishop score can help us determine readiness. Depending on the reason for induction and augmentation, some of this may change some of the pros and cons, but overall, when we think of pros, we think of that there's reduced risk of complications associated with longer or prolonged pregnancies. And we also know for some families or situations, the timing can certainly matter, so this may need to be factored in as well. In regards to the cons, there's certainly an increased risk for cesarean deliveries, and there may be an increased risk of fetal distress as well as the increased risk for hyperstimulation. However, that increased risk for fetal distress may actually be less of a risk depending on the reason for the induction of labor. So it just depends on what's going on with baby at that time. When thinking about oxytocin and its use for induction of labor, remember that oxytocin is a hormone that's naturally produced in the body and it causes uterine contractions. And Pitocin is the synthetic form of oxytocin. This is the medication that mimics the oxytocin, and we typically give it through an IV drip. It's used to start labor, it's used to make contractions more frequent, as well as to strengthen weak contractions. And we also use it to help prevent postpartum hemorrhage. Can also be helpful in delivering the placenta. As with all drugs, there's always risk involved. Um, Oxytocin or Pitocin causes contractions in the uterus, and some people are sensitive to these effects. So, therefore, these contractions may become too strong, and in very rare cases, this can lead to the uterus tearing. Also, if the contractions are too strong, there may be a decreased supply of blood and also oxygen to the fetus, which can obviously cause some pretty big problems as well. Let's take a look at I guess some of the other things that it could cause is water intoxication, which is a pretty serious condition as well. And then there's certainly more side effects than this, but I'll allow you to use your drug book to review that on your own. As far as giving the medication, basically you're going to have some specialized training if you're assisting with this, but we use an infusion pump and facility-specific protocols. And during any infusion, we want to monitor the fetal heart rate as well as the uterine tone very closely and discontinue it at the first sign of any hyperstimulation. All right, change topics a little bit and talk about Group B strep. Group B strep is the leading cause of newborn infections. Many adults with Group B strep have no symptoms, and the bacteria can easily be carried in the bowel, the vagina, the rectum, or the bladder, or even in the throat, and without someone ever even knowing that they have it. Group B strep is a type of bacteria that causes infections in newborns too. And when it does this, it leads to fevers, seizures, pneumonias, meningitis, also sepsis, all of which can lead to brain damage or developmental delays, as well as death. So, for this reason, we take extra steps to try to prevent this from happening in the newborn. Even though, fortunately, most babies born to women carrying Group B strep are healthy, but the few who do get infected can become very ill very quickly. And like I mentioned, these are life-threatening infections. So pregnant women are screened for Group B strep during their third trimester of pregnancy, and screening typically occurs somewhere around the 36 to 38-week gestation mark. Women who test positive for Group B strep should receive antibiotics during labor, and typical regimen is penicillin G, and we give this IV every 4 hours during labor until delivery. If anyone has an allergy to penicillin, we could use another drug like vancomycin. If the birth is going to happen via C-section and the membranes were intact, then typically no prophylaxis antibiotics are needed. But often, if the Group B strep status is unknown at the start of labor, then antibiotics can be given after a discussion with the provider to help evaluate what the risks really are. Chorioamnionitis is another type of infection. This is an infection of the placenta and the amniotic fluid that happens during pregnancy. It's also a pretty serious condition, and it does have implications for both mom and baby. It's typically caused by bacteria that comes up from the vagina or the anus, and it spreads to the uterus. In the US, it affects about 1 to 5% of births, and it's one of the causes of premature labor and delivery. So risk factors for chorioamnionitis include early rupture of the membranes, as well as a long or prolonged labor, having many vaginal exams during pregnancy, or having an amniocentesis, and also having a history of STIs could increase that risk as well. Symptoms are often fevers or sweating, but also uterine tenderness or foul-smelling discharge that often has an unusual color as well, and then tachycardia, either from mom or baby. Treatment's typically given intrapartum with ampicillin and gentamicin, and depending on the situation, the antibiotics may continue after birth and possibly for baby as well. Two topics I hope you remember. I believe we talked about these in the cardiovascular unit, but remember that preeclampsia is a pretty serious blood pressure condition that develops during pregnancy, typically after the 20th week of pregnancy. And people with preeclampsia usually have hypertension as well as high levels of protein in the urine. This is known as proteinuria. Preeclampsia can be serious because it can affect other organs in the body. It can cause kidney damage or liver damage, as well as brain injury and other serious problems too. It's pretty dangerous for both the mom as well as the developing baby. And because of this, during pregnancy, we keep a close eye and look out for symptoms related to this. It's actually pretty common, and it does cause about 15% of premature deliveries in the US. It seems to affect between 5 and 8% of all births. The symptoms of preeclampsia would be headaches, blurry vision with or without dark spots in the vision, right upper quadrant abdominal pain, shortness of breath, swelling in the face, hands, or feet. And then eclampsia is relatively rare but very serious complication of preeclampsia. Eclampsia is when the person with preeclampsia now develops seizures, and this occurs during pregnancy. It also typically occurs after the 20th week of pregnancy. Like I said, it's pretty rare. It affects less than 3% of people who have preeclampsia, but if this occurs, it requires emergency medical care. Risk factors for preeclampsia include being pregnant with multiples or being obese or having an autoimmune disease. Also, other risk factors are like having diabetes or hypertension or kidney disease. And age matters as well. So, keeping somebody who's younger than 17 or somebody that's older than 35 could be at a higher risk. The risk also goes up if this is your first pregnancy or if there's a personal or family history of preeclampsia or eclampsia. This chart really focuses on uterine atony as well as pharmacological management of postpartum hemorrhage. And this chart and all the information in it should look very familiar as we covered it not too long ago. We covered it back in week 11. So therefore, I'm not going to go into any details on this. I really wanted this to just serve as a refresher for you. Just keep in mind that uterine atony really refers to the tone of the uterus. Uterine atony refers to a soft or a weak uterus that occurs after childbirth, and it happens when your uterine muscles don't contract enough to clamp down on the placenta, or the placenta's blood vessels, I should say. Therefore, this can lead to life-threatening emergencies. It does require immediate medical treatment, which may include things like drugs like Pitocin or Methergine, and could require blood transfusions or IV fluids, as well as procedures to really tampen out that uterine wall, such as applying direct pressure to the uterus, and occasionally it does require surgical management as well. Switching it up to a totally different topic, we'll just briefly cover Narcan to help reverse respiratory depression in the newborn. Naloxone, also known as Narcan, is the brand name is Narcan, is used in addition to emergency medical care to help reverse the life-threatening effects of narcotic overdose. This can be used following delivery to decrease the effects of opioids that may have received prior to delivery. You do need to know that Narcan is not routinely used for all opioid-exposed newborns, and many things do need to consider before giving it, such as if the mother is an opioid dependent and if there are other interventions that can or should be trialed first, like providing PPV or positive pressure ventilation to the baby or other resuscitative measures. As many times these alone can really reverse the respiratory depression. If it is given, we do need to monitor the newborn closely because opioids can last much longer than Narcan, so Narcan may need to be readministered after some time. Last couple of slides here. This slide focuses on complementary and alternative agents. So midwives have been using herbs in their practice for centuries, and it's very common for women to ask their midwives for guidance on the use of herbs, both for including before, during, or even after pregnancy. The issue for the midwife is to find an evidence basis for the use of many of these preparations, and this can be really difficult. Here I'm just going to touch on a few. According to the NIH, the herb website, black cohosh is used for a wide variety of treatments like kidney issues, sore throats, menstrual cramps, as well as uterine stimulant to help induce labor. A 2023 review of 22 studies of products containing black cohosh extracts alone or in combination with other herbs found that they were potentially beneficial for overall improving menopause symptoms. There was data on specific symptoms showed improvements in hot flashes, but not anxiety or depressive symptoms. It's uncertain whether black cohosh can reduce hot flashes related to breast cancer treatments, and there aren't really enough reliable data to show whether it is effective for other uses. As far as safety, we know it can damage the liver, and in some cases, it has been very serious damage to the liver. Also, just like many other herbs, they're not that are not regulated. Many commercially sold products have been found to have contaminants or simply contain the wrong herb. Blue cohosh is a different herb than black cohosh, and the form, when it's used to induce labor, has been associated with some life-threatening complications of the infant, which includes seizures. Basically, the best evidence we have suggests that neither the black nor the blue cohosh are safe for use during pregnancy or while breastfeeding. Raspberry leaf is frequently used during pregnancy and labor to strengthen and tone the uterus, theoretically assisting contractions and preventing hemorrhage. And there is certainly a very long history of using this in pregnancy, but again, very little research to support this use. Many studies on this have concluded that there's not enough evidence to recommend it for the proposed purposes, and other studies were simply inconclusive. There was a big review that was done in 2021, and it concluded that while we can be reassured by the long history of the practice and lack of documented evidence of harm, contemporary healthcare practice demands that we examine the safety, the efficacy, um, of the use of raspberry leaf in pregnancy, and there's simply not enough evidence to support the use at this time. Evening primrose oil, primrose oil, goodness, have been used for a really long time also. And dietary supplements sell this for the promotion of atopic dermatitis, which is a form of eczema, for rheumatoid arthritis, for PMS symptoms, for breast pain, for menopause symptoms, as well as many other conditions. And it's certainly marketed as a cervical ripening agent or used as a cervical ripening agent, as well as both as an oral supplement, and also using it vaginally to help get labor started. You won't be surprised to learn that there's simply not enough evidence to support the use of evening primrose oil for any of these health conditions. While it has been suggested by many that it could get labor started towards the end of pregnancy by increasing the production of prostaglandins, studies have tested it and um, both orally and vaginally, and had pretty inconsistent results. As far as breastfeeding, it doesn't appear to be any more effective than placebo when taken orally, and it doesn't seem to be helpful for relieving the symptoms of atopic dermatitis either. The good news is that there's uh, not a lot of safety red flags, and best we can tell, it's safe for most adults when taken orally. There is less available information in regards to children, but it does seem to be pretty well tolerated. And the most common side effects that are found are usually GI related. And then lastly, castor oils is it's a vegetable derived oil derivative. It's primarily known for its laxative properties, although it's been reported also to aid in uterine contraction and even for antimicrobial activity. It does have an FDA approved use, and this is as a stimulant laxative. However, it's not first line treatment for constipation according to the current medical guidelines. In a few small studies, when used for uterine contractions, castor oil did show some promise, but also indicated that, guess what? Further research was needed to confirm its safety. All right. And then I saved this slide for last because I thought it just kind of fit well um, with the class. So I wanted to save it for last. I guess when looking at different strategies that can be used to help with labor pain, midwives are certainly the best at this, mainly because they provide a very individualized approach by considering a holistic approach, which includes things like continuous emotional support, but also physical support that could include things like birthing balls, massage or touch, hot or cold therapy, the TENS units, those transcutaneous electrical nerve stimulation units, hydrotherapy, so immersion in a warm bath or a warm shower. In addition to this, like those mind and body techniques, breathing techniques, relaxing techniques, just overall creating a very soothing and comforting environment, whether it's in the home or in an office type setting or a hospital. Some utilize things like music therapies or essential oils. There's also complementary and alternative medications, some of which we've discussed in this class, others which you may have used or heard about from the discussion forums. Acupuncture or acupressure can be used. Some use sterile water injections. And also just supportive care. So having the people who are most important to you, whether that be a spouse or your doula or your midwife, is just super important and comforting for many. In addition to this, one of the big things is empowerment, and that's through education. And that's where midwives typically thrive by spending ample time with the client prior to that birth experience to really prepare the patient for labor, to discuss the different pain management options and all of those techniques. So that is really all that I have for you guys. Thank you for all your dedication to this program. If you've made it this far in the class, you just certainly have dedication, as I know pharmacology is typically not always midwife's favorite class. So I wish you many healthy and happy deliveries in the future and hope that you take some of the information obtained in this course along with you on your journey. Take care. Remember that next week, no late work is accepted for that final week. So be sure to get everything completed and in on time, and reach out to me if you have any questions on any of the information or anything coming up. It has been my pleasure to work with you. You guys take care and have a great day or night, whatever it is for you.